Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick and Fox. We support the mesothelioma community by providing first-quality legal representation to mesothelioma patients and their families. During these troubling times, we're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
My name is Kelly Batley.
My name is Clay Thompson.
My name is Neil Mowney.
We are MRHFM, a national firm with 70 attorneys and 11 offices across the U.S.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
At Novacure, we strive to extend survival in some of the most aggressive forms of cancer through the development and commercialization of our innovative therapy called Tumor Treating Fields. Novacure is pleased to partner again with the Meso Foundation.
Good afternoon, Dr. Sterman. Thank you for joining us for this latest episode of MesoTV. Today's episode is going to focus on pneumonitis. And I know as a pulmonologist, this is an area that you treat and have really a good handle on how to explain just all about pneumonitis to this patient community. So thank you and welcome to MesoTV, Dr. Sterman.
My pleasure, Mary. Always a pleasure, honor, and privilege to talk with you.
Thank you. So, Dr. Sterman, what is pneumonitis? Can you tell us a little bit about, what it is and what it looks like on an X-ray?
Sure. So pneumonitis is a medical term that refers to inflammation of the lung, and it's often differentiated from pneumonia, which is another form of inflammation of the lung, but one that's associated with a type of infection. So pneumonitis is inflammation without infection of the lung, and on an X-ray often looks like an area of cloudiness. The lung on an X-ray should be almost transparent, so it should look black. So an area of cloudiness in an otherwise black background can be concerning for pneumonitis, often hard to distinguish just on an X-ray alone or even on a CAT scan from pneumonia. So one needs to get a very good clinical history from the patient and from the family, as well as looking at imaging to be able to make the diagnosis.
And is there ever a problem distinguishing progression of disease versus pneumonitis, or do they really, are they really clearly defined by a CT scan when you look at them?
Well, in mesothelioma, I think that you're dealing, obviously, in most cases, with a pleural malignancy, with nodules along the pleural surface, fluid in the pleural space, and occasionally lymph nodes in the center portion of the chest, the mediastinum, and in the hilar regions. Less so, but can be an involvement of the lung parenchyma. There are very rare types of mesothelioma that will invade directly into the lung through the what's called the visceral pleura, or the lining of the lung itself, and can look cloudy on an X-ray. It is not a very common presentation of mesothelioma. And so if there's any good news about pneumonitis and mesothelioma, for the most part, it is easily distinguished between disease progression and the presence of pneumonitis. More difficult would be distinguishing between pneumonia, an infection, and pneumonitis, inflammation without infection in mesothelioma.
Thank you. So in patients now that have had radiation therapy, can that be a sequela to pneumonitis? I mean, right. Is pneumonitis a sequela to?
So there are many reasons why someone can get pneumonitis. Radiation therapy which can be of significant benefit in mesothelioma, particularly in consolidating benefits of other therapies, including surgery or treating areas of pain, for example, in the chest wall, is well established, not just in mesothelioma, but in treatment of other tumors to cause inflammation of the lung. And what's interesting about radiation pneumonitis, and gives us a clue into why pneumonitis happens and how we should be treating it, is that radiation pneumonitis is not necessarily limited to the area where the radiation is administered. So you can, it's much more common in that region, but you can have inflammation distant to the area, even in the opposite lung from radiation. And that gives a really interesting clue about what's actually happening in pneumonitis and how we should be treating.
So what are the presenting symptoms of a patient who develops pneumonitis following radiation therapy?
So commonly would be a cough, a dry cough. It would be very uncommon to have sputum production, mucus production. And if the mucus is being produced, it's usually clear rather than yellow, green, or bloody. And shortness of breath. So it can be very subtle. The onset can be fairly insidious. It typically doesn't occur while the radiation is ongoing. It occurs typically after completion of the radiation therapy. So if someone develops a new cough or shortness of breath days into starting radiation, it would be really unusual for that to be directly related to the radiation. So the time course of radiation-related pneumonitis would be within a few weeks after completion of the radiation therapy. That's the most common time period. And again, the development of a persistent, often refractory dry cough and progressive shortness of breath, potentially associated with lower oxygen levels, both at rest, but especially with exertion. So if patients have pulse oximeters, which many patients have during the course of the COVID-19 pandemic, they may notice that their oxygen levels drop, and that can be a sign that the pneumonitis is there, even if their oxygen levels are adequate during just sitting around.
So now who treats the radiation-based pneumonitis? Would that be the radiation oncologist or would that be a pulmonologist?
I think many people treat radiation pneumonitis. I think that a good multidisciplinary program would have a system where a radiation oncologist who's treating a patient could discuss with a pulmonologist involved with the program, or even the medical oncologist if the medical oncologist is involved, and sometimes the thoracic surgeon if the patient's being treated with radiation in the postoperative or perioperative period. So it should really be a group decision because there are a lot of implications to treatment of pneumonitis, most notably the immunosuppression from giving the high dose steroids for the long periods of time that are often needed for treatment. So there are lots of implications and potential side effects of the treatment itself. And so it's best done in I think, a multidisciplinary fashion so that everyone is on board with the treatment, the course of therapy, and the potential side effects that the patient might be experiencing.
Thank you. So you mentioned that they're treated with high dose steroids. So typically, how are patients treated, and how long is the time frame?
Yeah, I would say some of the biggest mistakes that physicians make in treating pneumonitis of any cause, whether it be radiation-induced or drug-induced, is to underdose the steroids and or to rapidly taper them off too quickly. Because what will happen in that case is either the patients won't get better, or they will get better and then they'll have recurrence of the pneumonitis. And so there is an inclination, because steroids, corticosteroids specifically, have adverse effects, that you want to administer them to the patient and get the patient off them as quickly as possible. But you have to temper that inclination as a physician by the fact that if you get the patient off prednisone, which is the commonly used oral corticosteroid, too quickly, we see it rebound. And so often we will start with doses of around 1 milligram per kilogram of ideal body weight, which is somewhere around 60 milligrams of prednisone for most patients. sometimes as high as 80 milligrams, but for radiation pneumonitis, really no higher than 60 milligrams on a daily basis. Sometimes we'll divide up the dose in the course of the day, so we'll give 30 milligrams twice a day rather than 60 milligrams once a day. That is particularly if they have a lot of steroid-related side effects. But the other concern with giving steroids in the evening is that they can cause insomnia. So there is a rationale for giving a single dose in the morning so that patients can actually get a decent night's sleep and they're not up all night staring at their ceiling.
Now, is radiation, is this pneumonitis, is this curable?
Well, I think it's important to understand that there are two aspects of radiation lung injury. One is pneumonitis and the other is fibrosis. And so radiation pneumonitis is, as we said, an inflammation of the lung. The inflammatory component of radiation lung injury is reversible and curable with appropriate corticosteroid therapy, with prednisone and other corticosteroids. But often there is an associated permanent scarring of the lung that can coexist with radiation pneumonitis, even with early recognition and early treatment and appropriate doses and treatment course. And so it's important to recognize that there may be residual effects on the lung that you would see on an X-ray and a CAT scan, and clinical decline in pulmonary status. And that does not mean that the steroids were ineffective for the pneumonitis. It just means that underlying the pneumonitis was some fixed scarring that had already set in that's unfortunately not reversible.
Mm-hmm. So similar to what we see in some patients who've had surgery, that they develop scar tissue, and the scar tissue, can continue to grow even, months after the surgery.
That's right. And it's important for the clinicians as part of the multidisciplinary group to recognize what is pneumonitis and what is fibrosis, because you would not want to be treating fibrosis with steroids. The steroids are not going to help. If anything, they can lower resistance to infection. Patients with radiation fibrosis are prone to developing bronchitis. They're prone to developing pneumonia. And so if the steroids are not benefiting the patient, they could be causing harm. So it's really important to be following patients closely. Again, we don't want to be doing too many CT scans, but I will use chest x-rays to see if those hazy areas, the so-called ground glass component, are better, and whether there's an area of fixed scarring that is left over, and then not try to overtreat that area of fixed scarring, because I'm getting to the negative effects of the prednisone rather than any beneficial effects that they may have.
Thank you. So another question I have then, I know you mentioned it a little bit earlier, is that we have medical therapies induced pneumonitis. And I know that particularly today with immunotherapy, it is a risk that we run with immunotherapy.
Yes, I think that one of the miracles really of oncology in the last decade have been the introduction in a variety of diseases of immunotherapies. In melanoma and lung cancer, for example, these have been truly revolutionary in allowing patients with metastatic disease to live 5 years or more, or even be cured, where previously we really had no opportunity for that. In mesothelioma, we now, for the first time, have an approved immunotherapy combination for treatment of mesothelioma, and we hope to have additional immunotherapies, either as monotherapy in second line or potentially in combination with chemotherapy in front line, approved in the course of the next year, maybe even in the next several months. And we have many patients who are currently on clinical trials of a variety of immunotherapies. The issue with immunotherapy, whether in combination with chemotherapy or on its own, is that it can unleash immune responses against a variety of tissues in the body, not just the tissues of the cancer. And when you're treating a cancer of the chest with immunotherapy, there can be what we call cross-reactivity, which is that there may be proteins on the surface of the tumor cells that you want to stimulate the body's white blood cells to react against, to kill the tumor cells and prevent metastatic disease in the future or treat metastatic disease. But those proteins could be shared with normal cells in the lung. And so you may see cross-reactivity where, yes, you've stimulated an immune response against the cancer, which is a good thing, but simultaneously you've stimulated an immune response against the lung, the air passages, the small air sacs in the lung, and that's where the pneumonitis comes from. This is what we think happens in radiation therapy to the chest. This is why you might see inflammation outside of where the radiation portal is, because you're developing these immune responses to normal lung antigens, these proteins on the surface, which cause inflammation wherever those proteins are seen, which can be elsewhere in the body. The same thing happens with immunotherapy. And as exciting as it is, in my opinion, to have a combination immunotherapy approved for mesothelioma, we know from experience in other tumor types that this same combination comes at a very high cost of immune-related adverse events, most notably pneumonitis, this inflammation of the lung that we talked about. And this is seen much more in combination immunotherapy than in single immunotherapy, and much more with combination or single immunotherapy that involves what are called anti-CTLA-4 monoclonal antibodies, a specific type of immune checkpoint inhibitors that cause pneumonitis at a very high rate. They also cause inflammation of other parts of the body, including inflammation of the colon called colitis. And although there are a lot of serious immune-related adverse events, the ones that are most life-threatening are pneumonitis and colitis. And so they're the ones that oncologists have to watch very carefully for as they're treating patients with immunotherapy, especially combination immunotherapy.
Now, in patients who've had radiation therapy in the past and perhaps didn't develop pneumonitis at that time, is there a synergy between immunotherapy and past radiotherapy that might contribute even more to pneumonitis?
Yes, we're seeing what we call recall pneumonitis, which is maybe a misnomer, because a recall pneumonitis suggests that you may have had pneumonitis before, it got better, went away, and then you give immunotherapy and you now see it again. The way I think about it is recall pneumonitis may be inflammation of the lung, primarily in the area that's been radiated before, when immunotherapy is given, even if pneumonitis was not seen previously. And again, it has to do with how radiation works, how radiation kills tumor cells, that some normal cells may die too, and in the process of dying, they may expose proteins on their surface to the immune system that otherwise were hidden from the immune system, and that these immune responses may well be quiescent until they're elevated by the immunotherapy. And now we're seeing this immune reaction that may have been generated by the radiation, but really not manifest until we've unleashed the immune system. Again, remember what immunotherapy is. It often is not a stimulation of the immune system, rather by taking the brakes off the immune system. So we have brakes on our immune system for good reason. We have these brakes to prevent us from having autoimmune diseases like rheumatoid arthritis and lupus, where the brakes of the immune system are not functional. So we need to have these brakes. You can think of checkpoint inhibitors, these immunotherapies, as taking your foot off of the brake of a vehicle rather than putting your foot on the accelerator. But that's also dangerous, because when you take your foot off the brake, there may also be brakes on having abnormal immune responses against normal tissues in the body. And that is likely what's happening in pneumonitis, is that we are now unleashing abnormal immune responses against normal tissues, and now we have to treat that to prevent further damage to the lungs, to the organs, other organs of the body.
So, with mesothelioma being such a rare disease, and this new approval, I think we probably have to look at lung cancer to think of some of the questions. So I guess my question would be, we do know that there is a good percentage of patients now who are developing pneumonitis. Going forward with clinical trials, are we thinking about these particular groups of patients, and the types of treatments we can offer them following a resolution of this pneumonitis. Because I'm concerned that so many patients are seeking treatment, and I don't know that we have good answers yet, but we may have them in some of our sort of sister diseases.
Well, let me just take make a couple of points here real quickly. One is that pneumonitis is a problem for most cancers that are being treated with immunotherapy, but it's especially a problem for cancers that involve the chest, because patients will have compromised lung function, compromised chest wall function, so that they may be short of breath or have limited lung capacity or both going into starting therapy. And this is different from, say, a patient with melanoma, a skin cancer, that may have no involvement in the chest and has normal lung function. Pneumonitis can be a problem for them, but they had normal lung function going in. So for a patient with mesothelioma who comes in with shortness of breath related to tumor on the pleural surface, pleural effusion, gets treated with immunotherapy, they're going to be especially susceptible to the effects of pneumonitis related to immunotherapy. So I think that's first important. We have to understand that mesothelioma, and I would include lung cancer in that group of thoracic cancers, is a unique subgroup in which we worry about pneumonitis specifically. And then in mesothelioma, we have some patients who undergo pneumonectomy, removal of an entire lung. Again, this puts them in a unique category where they may have only one residual lung, and that lung may be otherwise normally functional. But if you only have one lung and you develop pneumonitis in that lung, well, you're in very big trouble. And recognition and treatment in an expedited fashion is exceedingly important. And then we get to the question that you bring up, Mary, which is, okay, what do we do? Some of these treatments of immunotherapies, like the combination immunotherapy that's been recently approved in mesothelioma, can be really revolutionary for subgroups of patients. Not for everyone, but for subgroups. So let's say, for example, you have an advanced mesothelioma, you get started in immunotherapy, and your tumor starts to melt away. It's like a miracle. It's wonderful. It's what everyone is hoping for, the patients, the family, the oncologists. But then pneumonitis comes in, and the patient now is short of breath, and they're coughing, and they're on oxygen, and you need to treat with prednisone therapy to make the pneumonitis better. Now you're faced with a dilemma, because you've had to hold the immunotherapy during the treatment for the pneumonitis, and you've made the pneumonitis better. Do you restart the immunotherapy? A treatment that may have helped a patient substantially. What we do know is that there are significant risks of re-challenging patients with immunotherapy who've had significant immune-related adverse events, especially pneumonitis. And so for a patient with mesothelioma who may have had pneumonitis that's been significantly impairing to their quality of life, or even potentially life-threatening, I think, unfortunately, this is where the pulmonologist has to step in and say, I'm sorry, I know this therapy has been very effective, but I don't think that it is worth the risk of restarting the therapy once the pneumonitis has been treated. And that's a very difficult discussion with the oncologist and with the patient and with the family for someone who may have had a significant benefit from the treatment.
So I guess this really leads to the need for, even though immunotherapy has been a godsend for many patients, that we do need to continue alongside of it, developing better, smarter, targeted, oncology products for those patients who perhaps now will be in need of something else following, this development of pneumonitis. So, we have gemcitabine and we have navalbine. What do you think about either of those two drugs in patients who've already had pneumonitis?
Well, gemcitabine worries me because gemcitabine is one of the chemotherapy agents that is associated on its own without combinations with immunotherapy as causing pneumonitis. Before we had immunotherapy, I was treating gemcitabine-related pulmonary toxicity. Navalbine, not so much in terms of causing pulmonary toxicity, more bone marrow toxicity in my experience. And so you weigh the efficacy of the drug from what we know versus the potential risks of causing pneumonitis in patients with mesothelioma. And so, and then you even think about whether if a patient has been on dual immunotherapy, dual checkpoint inhibitor therapy, develops pneumonitis, do you re-challenge with one immunotherapy agent? I told you that it often is the anti-CTLA-4 antibody that is the culprit here. And so you think about whether you would re-challenge just with the anti-PD-1 or PD-L1 monoclonal antibody in a patient who's recovered from pneumonitis. So there are lots of considerations. We don't have a lot of answers yet. I will also say on the pulmonary medicine side, we are trying to learn whether we can predict who those patients are who will get pneumonitis. And learning, and there are ways that we are figuring out that there may be predispositions. Radiation therapy is one of them that you mentioned, but there may be other inherent characteristics, maybe prior pneumonia, maybe prior history of autoimmune disease. Maybe there's a family history of rheumatoid arthritis and lupus in the family, or a personal history of psoriasis or lupus. There may be even characteristics of the lung that we can discern up front before starting on immunotherapy that can tell us who's going to be at high risk for pneumonitis. And we're learning that, for example, the characteristics of the bacteria that may be resident in the lung, the so-called microbiome, may play a major role. And even the gut microbiome, even though it's far away from the lung, may play a major role in who develops pneumonitis or who responds to immunotherapy, or potentially both. So we have a lot to learn about how, for example, the normal organisms that live in our lung and live in our gut, even potentially in other areas like in our nasal passages in our mouth, interact with the medications that we give to cause both benefit as well as side effects from these medications.
Thank you. Dr. Sterman, this has been extremely helpful. Helpful to myself, who speaks to so many patients, and certainly going to be very helpful to those who will be listening in on this really important discussion. So I want to thank you for your time. I think you've given us a tremendous amount of information about pneumonitis and how it's diagnosed, treated, some of the things that clinicians need to think about in terms of future treatments for patients. And is there anything else that we didn't discuss that we should?
Obviously, we're developing new therapies for pneumonitis, which we hope will be less toxic than high doses of corticosteroids. For right now, we use them for patients who are refractory to steroids, but we're hoping to have better therapies that are less toxic and even potentially may allow us to restart immunotherapy in the future while treating patients for this. So we have a lot to do on the treatment of pneumonitis side as well as on the treatment for cancer side.
Well, thank you very much, and I really appreciate you having taken the time to spend with us today. And again, thank you on behalf of all of the patients that you're treating with mesothelioma, as well as all the COVID-19 related cases. You've done a fabulous job, and you put a lot of time, effort, and energy into everything that you do. So thank you, Dr. Sterman.
Thanks for having me.
Really appreciate you. Thank you. Bye.